All right, let's dive into microtia. It's a really key topic for your plastic surgery boards, a congenital thing affecting the external ear. We need to get into the embryology, associated issues, timing, the techniques, basically everything you need to know.
Exactly. And worth remembering, it's more common in males, about 2 to 1. And we see it more in certain populations too, Asian, specifically Japanese, Hispanic, and Navajo groups.
And it all starts with those first and second branchial arches, doesn't it?
That's right. Development kicks off around the 6th week near the first branchial cleft. You get these 6 little bumps, mesenchymal buds, called the hillocks of his.
Helix of his.
Yeah, 1 to 3 are from the first arch, the mandibular arch, and then 4 to 6 are from the second, the hyoid arch.
And they all fuse together to form the ear.
Eventually, yeah. The lobule, the earlobe, that's actually the last bit to form.
So that 6 to 8 week window in gestation is really critical then.
Absolutely crucial. Any disruption there could be teratogens, like Accutane, retinoic acid, thalidomide back in the day, or maybe ischemia or
Yeah.
genetic factors. That's when you can get microtia.
And if the problem happens later?
Usually less severe. Later insults tend to cause sort of milder deformities.
Okay. So moving on from development, what about associated abnormalities? What else should you be looking for?
Well, very commonly you'll find issues with the middle ear and the external auditory canal, the EAC.
Right.
But interestingly, the severity of the outside deformity, the microfocia itself, doesn't really correlate well with how bad the middle ear function is.
That's a key point. So what kind of hearing problems do we typically see?
It's mostly conductive hearing loss, maybe 80–90% of the time. That's usually down to problems with the ossicular chain. The little bones might be fused or underdeveloped, the malleus and asucus, or sometimes they're missing altogether. Oral atresia is also common.
Atresia meaning the canal is narrowed or completely closed.
Exactly. Stenosis is narrowing, which carries a high risk of cholesteatoma, something you need to watch for. Or it could be complete EAC atresia.
Is there a way to predict if surgery might help the hearing?
Yeah, the Jarsdorfer criteria. You look at the CT scan, score different features of the middle ear. A score over 7 out of 10 generally suggests a better chance of hearing improvement with surgery.
Good to know. And are there specific syndromes we need to link with microtia for the exams?
Definitely. Think branchial arch syndromes, Goldenhar's, Treacher-Collins, ocular auriculovertebral dysplasia. Hemifacial microsomia is a big one that involves mandibular hypoplasia and microtia. Actually, isolated microtia is sometimes considered the mildest form of hemifacial microsomia.
Any other associations?
Yes, you can also see things like facial clefts or cardiac defects in maybe up to 30% of cases. Less commonly, things like anophthalmia or microphthalmia, limb reduction defects, renal malformations, even holoprosencephaly, though that's rare, maybe 7%.
Okay. So when we think about fixing the ear, the auricular repair, what are the main goals?
Primarily, it's about improving acoustic function, helping with sound localization, speech perception. That might involve hearing aids, bone-anchored devices, or sometimes canalplasty alongside the ear reconstruction.
And secondary goals?
Well, improving speech development, social acceptance, emotional well-being, those are really important too, especially as the child gets older.
Makes sense. What dictates the timing for surgery? It's not done right away, is it?
No, definitely not. Several factors come into play. You need the external ear to be reasonably mature. It's about 85% of adult size by age 4, but width keeps growing until 10.
And the rib cartilage?
Crucial. You need enough donor rib cartilage for the framework. That's usually adequate by age 5 or 6, sometimes a bit later depending on the child and the technique.
What about school age?
That's a big factor. Psychological aspects, peer interaction. Many prefer to operate before the child faces significant teasing. Then there's coordination with any middle ear surgery. Usually, the ear reconstruction comes first. You have to plan the canal position, flat blood supply, incision placement carefully with the otology team.
And managing the hearing deficit itself.
Right. Conductive hearing aids are common early on. If osseointegrated devices are planned, you need to think about placement relative to the reconstruction. And the technique chosen influences timing too.
How so?
Well, autogenous cartilage is the gold standard, really. But for Brent's technique, you might start around age 4 to 6. For Tagata, it's typically later, maybe age 10, or when the chest circumference hits 60 centimeters, because you need more cartilage.
So a comprehensive workup is needed beforehand.
Absolutely. Evaluation by both plastics and ENT, ideally within the first year and then annually. Family history, genetic counseling if needed, a full physical exam looking at ear structure, facial symmetry, nerve function, dental occlusion. Audiometry is key to know if it's conductive or sensorineural loss. And imaging high-res CT of the temporal bone for the middle ear, maybe an MRI to check the facial nerve course, or look for cholesteatoma.
Let's talk classification. How do we categorize microchias?
Several systems exist, but Nagatas and Tansers are common, often based on what surgery is needed.
Yeah.
You basically have a no-shoe, complete absence.
Yeah.
The lobular type, just a lobule and maybe some helical remnant, but no real concha or tragus.
Okay.
Conchal type has more structure. A remnant, lobule, concha, meatus, tragus are all there, just small. Small conchal type is simile, but with just a small conchal indentation. And then there's atypical for everything else that doesn't fit neatly.
And the treatment options, you mentioned autogenous cartilage.
Yes, autogenous costal cartilage graft. That's really the best long-term option, pioneered by Tanser, modified by Brent and Nagata. It integrates, well, grows with the child to some extent.
Downsides.
Well, donor site morbidity is the main one. Potential for pain, pneumothorax, maybe some chest wall deformity later, though techniques aim to minimize that. And it usually requires multiple stages.
What about other options? Silastic.
Silastic frameworks like Cronin used gave great initial aesthetics, no donor site issues, but they had high rates of extrusion, infection, problems with minor trauma. They're really not used anymore for primary reconstruction.
MedPor. Porous polyethylene.
That's Reinish's technique. It offers good short-term results, avoids the chest donor site, but we lack really long-term data on extrusion rates and durability compared to cartilage.
And prosthetics.
Osseointegrated prosthetic reconstruction is an option. It can be useful if the tissue is poor, maybe after failed autogenous attempts, trauma, cancer, radiation, or in older patients. But it depends on technology, skill, cost, durability can vary. It's usually more of an alternative or salvage option.
Tissue engineering. Still on the horizon.
Still mostly research. Getting the right scaffold and cell source is tricky. Some promising studies with non-human chondrocytes, but not standard practice yet.
Okay, let's zero in on the two big autogenous techniques, Brent and Nagata. How does Brent's work?
Brent's is typically 4 stages. Usually starts younger, maybe age 4 to 6. Stage 1 is harvesting cartilage, usually contralateral ribs, 6, 7, 8, carving a high-profile framework and placing it in a subcutaneous pocket.
Contralateral ribs.
Yes, to mimic the natural curve. Then stage 2, months later, is transposing the lobule into position. Stage 3 is about projection, lifting the ear off the head using a banked cartilage wedge or maybe a polyethylene block, advancing retroauricular skin, and often needing a split-thickness skin graft behind the ear.
And stage 4.
That's for refinements. Constructing the tragus, often with a composite graft or a conchal flap, maybe deepening the concha, adjusting symmetry. Though nowadays many incorporate the tragal component into the initial framework in stage 1.
Right. And how does Nagata differ?
Nagata's is usually 2 stages, starting later, around age 10. Stage 1 involves harvesting more cartilage of ipsilateral ribs 6 through 9, leaving the perichondrium behind to help with chest healing. He creates a very detailed, high-definition framework, including the tragal component from the start.
Ipsilateral ribs this time.
Yes. And he uses a W-shaped flap for skin coverage and transposes the lobule at the same time. So stage 1 is quite complex.
And stage 2.
Stage 2 comes about 6 months later. That's for elevation. He uses another cartilage block, often from the 5th rib, placed behind the framework to project it. This elevated framework is then covered with the temporoparietal fascia flap.
The TPF flap.
Exactly, a very reliable flap for covering cartilage. And then a split-thickness skin graft, usually from the scalp, goes over the fascia flap to cover the remaining defect.
Okay, different approaches. What about post-op care? What's critical?
Hemostasis and getting the skin to stick down to the framework contours are vital. Brent often used a closed suction drain. Nagata prefers a tie-over bolster dressing. Either way, careful monitoring for infection, hematoma, or any signs of skin exposure is crucial.
Activity restrictions.
Definitely. No sports for usually 3 to 6 weeks to protect the reconstruction.
And complications we need to anticipate.
Skin loss is a big concern. Prevention is key. Meticulous dissection, preserving blood supply, especially the superficial temporal artery if using a TPF flap, avoiding too much tension or pressure. Small areas might heal conservatively, but larger areas need prompt debridement and maybe flap coverage.
Infection.
Less common with cartilage than implants, but still a risk, especially if there's exposure or underlying middle ear pathology. Look for redness, swelling, drainage. Prevention involves good cleaning, addressing any ear canal issues. Treatment is usually with irrigation and antibiotics.
Hematoma.
Rare, but potentially devastating for the graft. Needs early recognition and immediate drainage.
And donor site issues from the chest.
You can get a pneumothorax, though careful technique and maybe an intraoperative catheter can manage that. Atelectasis can happen, but local anesthetic infusions help with pain and breathing. Chest ball deformity risk varies, maybe higher in younger kids, but leaving the perichondrium, like in Nagata's technique, might reduce it. And scar hypertrophy is always possible.
Any long-term things to watch for?
Suture extrusion can happen, usually just needs simple excision. Some degree of cartilage resorption is possible over many years, might need regrafting in rare cases. If the hairline is low, incorporating hair-bearing skin into the reconstruction could be an issue. Prevention with laser or careful planning is best. And sometimes, over time, a relative size discrepancy can emerge compared to the other ear.
Okay, great overview. So, to wrap up the key points for board preparation.
Right. Remember the embryology, first and second branchial arches, hillux of his. Know the common associated anomalies, especially middle ear and syndromes like Goldenhaar's and hemifacial microsomia. Timing, usually reconstruction starts around age 6 or later, depending on technique and cartilage.
And the techniques themselves.
Autogenous cartilage is the gold standard. Be familiar with the stages and principles of Brent and Nagata, the number of stages, age, cartilage source, elevation methods, and understand the role of the temporoparietal fascia flap, particularly in Nagata's technique, for reliable soft tissue coverage.
Excellent. Sounds like a solid foundation.
Absolutely. But, keep digging into the details. Look at the anatomical nuances, review the outcomes. That constant study is what really prepares you for the exams and for practice.